happy to be here today. I'm recently joined Christiana Care as John said, as the clinical ethics lead, and so I've been helping talk a little bit about medical aid in Delaware, mostly in our institution. Um, I have no financial conflicts of interest, and then I always start with a disclaimer that this is just sort of my own, thoughts and um, research on medical aid in dying. It doesn't represent the views of the ethics committee as a whole or Christiana Care as an institution. My goal today is to give a brief introduction to medical aid in dying, talk again briefly about the medications themselves and the ingestion process. I'll probably leave some of that to Crystal, and then get into the law that's active in Delaware now, and a couple of thoughts about what this is going to look like in practice going forward. Please feel free to unmute if you have any questions. You can also put questions in the chat. And as long as I'm sort of glancing off to my right, I should be able to answer those as they come up. So for anyone unfamiliar with the terminology, the process we're referring to is called medical aid in dying. Compassion and Choices is an advocacy group, and they define that as the practice by which a terminally ill, mentally capable person with a prognosis of 6 months or less chooses to request, obtain, and take a medication that brings about a peaceful death. This is generally the term that's used in the Delaware law too, so uh, it's what I will use throughout the talk. There can be some confusion in the terminology. So medical aid in dying is distinct from euthanasia. The important distinctions are that in euthanasia, another person, so not the dying person, sort of has the final act to cause the death. Euthanasia is not necessarily voluntary, whereas medical aid in dying by definition is. And euthanasia is still completely illegal in the United States. But as we will see, more and more states are legalizing the process of medical aid in dying. Um, the other term that gets thrown around is physician-assisted suicide. And so there can be some confusion about whether medical aid in dying is the same as physician-assisted suicide. I'm going to highlight that the law in Delaware specifically states that this is not considered suicide or assisted suicide. The Compassion and Choices group also offers sort of a couple of distinctions between medical aid in dying and assisted suicide, including the idea that the patient is determined to be competent, that they have a terminal illness, and some other sort of feelings or beliefs that they have about sort of the importance or legitimacy of medical aid in dying as opposed to, physician-assisted suicide or suicide. But I do like to highlight this because physician-assisted suicide is still a term in use. The American Medical Association Code of Ethics would describe this process as physician-assisted suicide. It appears in sort of various ethics textbooks. And so some people will be referring to it that way. Now that it's legal in Delaware, I have a pretty strong recommendation that we ought to be using medical aid in dying, just because what we don't want to do is create confusion as to whether or not we're talking about a legal or an illegal practice. I also kind of get the sense that physician-assisted suicide is becoming much more of a pejorative term, and it tends to be used more by people who object to the practice. So it's interesting to sort of look at this practice and the attitudes about it in the United States over time. This is a Gallup poll, and they've been doing this for almost 30 years now, asking whether the American public is in favor or opposed to practices that are sort of adjacent to medical aid in dying. And so the green line is support for this question. When a person has a disease that cannot be cured, do you think doctors should be allowed by law to end the patient's life by some painless means if the patient and his or her family request it? And that gets quite high approval rating. So the the majority of the public would seem to say yes, that should be allowed. And interestingly, the question would seem to describe euthanasia a little bit more to the point than it describes medical aid in dying. And they ask a related question, which is when a person has a disease that cannot be cured and is living in severe pain, do you think doctors should or should not be allowed by law to assist the patient to commit suicide if the patient requests it? And there's two important language differences between the first and the second question. One is the second question stipulates that the person in question is in severe pain, and the other is that it uses the word suicide. And so you can see that that has a pretty reliably lower acceptance level than the first question. And my guess is that's because of the stigma that comes along with suicide, because otherwise it doesn't seem like there are really big differences between the two. But regardless of the way the question is worded, it is generally viewed as acceptable by the public, at least according to this data. People have surveyed physicians about their opinion on this. The results are quite variable. In general, it seems like physicians have a slightly lower support than the general public. And then naturally, there's an even lower level of willingness to participate in the practice. But it's a little bit all over the place. And then the different professional organizations and societies have occasionally issued opinions on whether medical aid in dying or physician-assisted suicide is an acceptable or unacceptable practice. Probably most notably is that the American Medical Association and the American College of Physicians have come out as opposed to this. The AMA has a more recent qualification that would sort of seem to say, if you have a strong reason by conscience to think this is a good practice, it's okay if you participate. But I think generally their stance is still one of opposition. A couple of societies, interestingly, have not put out any position on this. And then there's a lot of neutrality. The one that I could find that supports the practice is the American Medical Women's Association. But regardless of those positions, it is growing in the United States. I think this map is now actually outdated, even though it's quite recent. So Delaware was, I believe, the 12th state or jurisdiction to legalize it. I think New York and Illinois have also legalized it since I created this talk back in the fall. And so more and more states are allowing it. The light blue states are the ones where it is legal. The dark blue states are states where there is active legislation, although I don't think there's any strong feeling that the legislation is necessarily likely to succeed. So, I've heard mixed things about Pennsylvania. I practiced in Massachusetts for about 10 years, and it would sort of come up every so often and then get sort of kicked down and not go through. Because the practice is spreading, some people have raised a concern about whether we're on a slippery slope here. And these are just two articles. The one on the left is from the Atlantic, excuse me, and it's called Canada is Killing Itself. And it sort of chronicles Canada's journey through legalizing euthanasia and then, as time has gone on, expanding access to it. It's an interesting article to read. It does, I think, in my opinion, paint a little bit of a picture of a slope. I don't know if you should say that Canada is slipping down it as opposed to just sort of willingly walking down it. But there's been some expansion in Canada. And then the Netherlands is probably the other country that's talked about most commonly. They've had a long-standing both tradition and then legal practice of euthanasia. And so they've started to come up against the boundaries there. And a couple of years ago, there was a fairly controversial case of a 29-year-old woman who we could say was physically healthy, but had intractable mental illness. And after some debate was ultimately granted permission to receive euthanasia, and then did receive euthanasia. So this picture, I think, was taken shortly before her death. So these are controversial things. In the United States, Again, people worry about a slippery slope. Um, you can kind of look at the legal history to choose for yourself whether you think we are on one. There have been some changes to the laws that have passed over time. So Oregon was the first state to legalize this back in 1997. And it has changed the law slowly over time to waive a waiting period, and then more recently to allow non-residents to receive medical aid in dying in their state. There have sort of been other challenges or changes to laws around the residency requirement and around the waiting period. But I will say in 30 years of this being practiced in Oregon, it seems like the law is largely the same as it was back then. Um, Oregon has done a good job for a long time tracking data on this. So I wanted to just take a little bit of time looking at the experience and the data that come from Oregon as a sense of sort of what this can look like in states where it's been present for a long time. So each year, Oregon publishes a data summary called the Oregon Death with Dignity Act Data Summary. I believe Delaware is also going to be required to publish a similar summary. This is from 2024. They did just come out with a 2025 summary. I didn't notice any massive changes. I'll mention one or two small ones. But in the year 2024, a little over 600 people received prescriptions in Oregon. They have roughly twice the population of Delaware. And then not everybody who receives a prescription necessarily ingests the prescription or fills it. And so right now there's sort of like a 50 or 60% known ingestion rate. They track demographics. So the majority of the patients are older. And then interestingly, the vast majority of the patients are white. And this has actually been shown to be true across multiple states, including California and New Jersey, which have a much lower percentage of their state population that's white. One of the reasons I highlight this is one of the earlier concerns about medical aid in dying is that it might be inappropriately forced or pushed towards vulnerable populations. And I will say the data don't really seem to bear out that concern. And in fact, some people think that the opposite happens. And in fact, and this is like a practice that is only available to the sort of the wealthy and the privileged. And we'll talk a little bit about why that might be the case. And then Oregon's tracked the qualifying diseases, so the terminal diagnoses that are used when applying for the medical aid in dying or requesting medical aid in dying. Cancer is by far and away the most common. It has been starting to come down a little bit in recent years, and heart disease has been starting to come up. I've seen this trend a little bit in other states too. So generally, cancer, again, is by far the number one reason patients request this. Neurologic diseases and heart disease tend to be sort of around two or three in most places. Another interesting thing about Oregon is the practice has continued to grow. You can see for many years it had sort of this slow beginning since the time that it was legalized in 1997 and then started in 1998. But it's grown over time. In the most recent data summary, maybe we're seeing a little bit of leveling off. But based on this, I'm not convinced that there's been a plateau. Um, and I thought that was kind of interesting to note too. So there tends to be sort of a slow up, a slow start, and then gradually increasing over time. The other thing that Oregon does that I really like is they actually survey patients about the end of life concerns they have that lead them to request medical aid in dying. And so you can choose more than one concern, but this gives a sense in Oregon of what the most common concerns are that lead to the request. Um, and you'll see that a lot of them are sort of um, they're interesting. So losing autonomy is the most common. Um, Losing sort of enjoyable activities in life or loss of dignity are two and three. But inadequate pain control or concern about inadequate pain control, is way down here at number 6 in Oregon, and it's much lower than I would have expected before I started looking at this data. I think in my imagination, this was most often happening from patients who had intractable pain or physical suffering as a result of their terminal illness, and that was sort of the relief that they were seeking. But more commonly, it's related to ideas of autonomy and dignity, and sort of what daily activities make a life worth living. And again, if anyone has any questions or comments, please feel free to interrupt or put them in the chat. I'll sort of keep marching through though. Um, so this is a messy little graph, but it tracks the different medication regimens that have been used over time. So as this practice has kind of grown and evolved, people have been sort of trying different things to basically reliably achieve a peaceful death. And so you can imagine this isn't really well established in the practice of medicine. So knowing exactly what medications are most useful for this purpose wasn't something that you could sort of consult the textbook for. And it's very different from euthanasia, where medications can be given intravenously. And so the types of medications are a little bit different there. For the last few years, things have settled on this 5 medication regimen, DDMAPH. These are the drugs down here, and I'll get into that in more detail. And that really has become the most common. Although in the last year, I noticed another one is starting to come up. I think they're starting to get rid of the diazepam, but I could be misremembering that. But this now is sort of the most common regimen that's used. There's a group called the Academy of Aid in Dying Medicine, and they provide clinical guidance for this. And so I'll show you some of their clinical guidance. Um, and I just want to make it clear that this is not my own personal advice. I don't know if Crystal is going to get into this, but this is not something that I've ever prescribed. So I'm going to put up sort of the doses that are used, but with the very big caveat that, this is stuff that I've taken from the website for the Academy of Aid in Dying Medicine. Um, so what I've done is I've listed each medication, and I've listed the recommended dose for medical aid in dying. And then I've given my own opinion on a typical dose. Okay, so you might not be too impressed with my digoxin dosing or something like that. But then also the fold increase between what I would call a typical dose and the dose that is used to achieve medical aid in dying. And so the take home from this is that the doses of these medications are pretty staggering. And as a result of this, people obviously aren't actually taking 1,000 tablets of morphine. The medication has to be produced at a compounding pharmacy. And so it's generally dispensed as a powder in a clear bottle. Um, and there's a lot of medications in there, and there's a lot that kind of goes into the ingestion. And I'll keep this quickly again because we have Crystal who can talk about this. Um, but there is sort of guidance that's recommended for clinicians, but also for patients and families who are considering this process. So to my knowledge, this is not covered by any commercial or government insurance company. And so the cost is out of pocket. And the quote that I see is around $600 to $1,000 for the medications. It's recommended that the medication be kept at the pharmacy until the final decision is made. So even after the prescription is written, people will tell families like, don't go pick it up until you know that this is actually something you're going to go through with, not just for the cost, but also so that the medication isn't sitting around the home for a prolonged period of time. And then there's practical guidance to make sure that a person who is sick and at their end of life can safely take the medication when they might not be used to taking, turns out to be a couple ounces of, a pretty offensive tasting substance. And so the website does kind of go through all these ideas about having contingency plans. So if you start the ingestion, but you vomit or you can't complete it because of the taste, what is your plan there? What support do you have in the home? This is predominantly done in the home. It's relatively rare that it's done in an inpatient setting. Um, and then there's also guidance that that sort of focuses on actually mixing and preparing the medication. Um, once the once the medication is ingested, and most often it's ingested by mouth, although there are sort of reports of it being administered rectally through a rectal tube for patients who are unable to swallow. Typically, there'll be this period of deep sleep that happens relatively quickly, followed by a coma-like period. And then sometime after that, the patient will die. And when possible, Oregon has sort of tracked the time from ingestion to death. And so the majority of the time, it seems like that happens within an hour. There's a decent minority of patients where it's a little bit prolonged and it can take up to 6 hours. And then a small subset of patients um, that seems like it takes much longer than that. And so there are sort of reports of it taking up to a day or something like that. And it's thought that there's usually some kind of physiologic reason for this, either because the GI tract isn't absorbing well, or because some patients might be younger and healthier, even though they have a terminal diagnosis. Some people have speculated that former high-level athletes take longer. It might have to do with sort of the healthiness of the heart and things like that. Um, so that's sort of a quick review of the ingestion. This is kind of the background. I'm going to transition next into the law in Delaware, and so what the current status of the law is here. I'll pause for just a second to see if there's any other questions or comments from the audience, though. All right. So again, feel free to unmute or
Yeah, sorry, Jim. Had to find my mute button.
yeah,
Um, yeah, I just noting on the sort of the psychographic of this, you were talking earlier about, like clearly there's a demographic group. I think this is also the same demographic group that was um, primarily moving the law,
yeah.
and I think it's an interesting kind of psychographic desire for this that probably is not shared more widely. And I agree. I think it's feared in some places too. So,
Yeah, I agree. It is interesting. It does seem, and I've talked a little bit informally with some of the psychologists at the cancer center here and stuff like that. Um, there does seem to be a particular demographic that both seeks us out and then also, and as I get into the details of the law, like it is a logistical process to get through. And so I think with the sort of Venn diagram overlaps, you kind of get a particular population that tends to go after this. And as you mentioned, I think a similar population that is in a position to advocate for legislative action and things like that. Um, so it's almost been a year now, but about a year ago, Governor Meyer signed the law into action. And the law became, sorry, he signed the law and then it became active on January 1st of this year. If someone wants to throw in the chat, please correct me, but last I checked, I have not seen the final regulations. It was a couple of weeks ago that I checked last, so I might be incorrect about that. So I believe we're still waiting on the final regulations from the state, but the law is active, prescribing is legal. And basically, I've tried to boil the law down as simply as I can, and it basically establishes that a patient who is an adult living in Delaware with a terminal illness and a prognosis of 6 months or less, who has decision-making capacity and the capability of self-administering a medication and is not being coerced, can make a request to a physician or nurse practitioner for a prescription for the medication to end their life. And then a physician or nurse practitioner, and the law uses the term attending, so an attending physician or nurse practitioner who has primary responsibility for the individual's terminal illness and provides treatment not limited to dispensing medication to end life and has gone through sort of the legal process and the requirements, may prescribe medical aid in dying. Um, I'd like to highlight participation as optional. So the law, I think, without any sort of like caveat or stipulation, allows for a prescriber to choose not to prescribe or participate for an individual patient. Um, but individual prescribers are legally allowed to. Um, and so that's what the law establishes. The process is a bit more complicated than that, and it is detailed in the law. This is sort of the patient-facing process. Um, and the way it's designed, the patient has to make a request for the medical aid in dying, and then 15 days must pass before they make a second request. And they have to provide a written request. And the preliminary forms give a template for the written request. And there's rules about how the written request is completed. So it has to be signed and dated by the patient, and then it has to be signed by at least two adult witnesses. These are sort of similar to the rules around advanced directive documents. Um, and that has to be provided to the prescriber. And then after the written request has been received, at least 48 hours has to pass before a prescription can be written. And so, again, you can imagine for a patient, this is multiple visits over a short time at a potentially difficult time in their life, the last 6 months to make visits. It requires witnesses that are unrelated to the patient. And so there's a decent amount of logistics. And then there's even more sort of logistics for the prescriber. Um, this is a little bit of a high-level summary. So the prescriber is expected to confirm Delaware residency, attest to the terminal illness, at least attest that the patient has decision-making capacity in their opinion, or refer to psychology or psychiatry if there's uncertainty. They are expected to confirm that the decision is voluntary, that they have reviewed other end-of-life treatment options, that they've reviewed the risks of taking the medication. There's a lot of counseling that is described in the law. And then a second physician or nurse practitioner acts as a consultant. So the consultant just confirms the diagnosis and prognosis, provides written confirmation in the record, confirms decision-making capacity if needed. Um, this is sort of a little bit more detailed discussion of the things that are outlined in 2508C of the law. And then the state has published, again, I think it's still preliminary forms. And so these are the forms that the prescribing attending is expected to complete prior to dispensing the prescription. And so you probably can't read any of this, which is fine. There's 5 pages, but it goes through like attesting to all the different, counseling that's expected to happen prior to a prescription being written. And again, there's a consultant who has to be involved as well, and they have their own, attestation forms that they've sort of evaluated the patient and confirmed, the prognosis and things like that. And then after all that is done, the prescriber is supposed to file a report with the state and the prescription can be dispensed. And it is the state's expectation that after the patient dies, the prescriber then files like a post-death form that talks about the cause of death, whether or not the patient was enrolled in hospice or palliative care, that sort of thing. Um,
So, Jim, this is John Goodall. It sounds to me like all of that stuff makes it pretty hard from a practical standpoint to be like an average primary care doctor or something like that and do this work. It seems like the language of the law is trying to prevent a practice specifically aimed at doing this all the time also.
Yeah.
So it kind of suggests to me that the only people that are going to be doing this are people who work with terminally ill patients. Um, and obviously some of them won't choose, most of them won't choose this, but some will.
Yeah.
So
So,
it kind of falls on hospice a lot.
yeah, we will talk about all that, but I do want to highlight the point you're making. Sorry to scroll back. So, you know, this second sentence, providing treatment not limited to dispensing medication to end life. I have not seen that in the other laws that were passed in other states. Um, and I think there's sort of two possible interpretations. I think the permissive interpretation of that sentence is that what you're not allowed to do in Delaware is start up a MAiD practice, where this is just what your job is. And basically, you're seeing patients for the purpose of prescribing MAiD, and that's mostly the only thing that you're doing. I think that's a conservative reading of that sentence, I guess, in one sense. You know, the way the sentence is actually written makes me wonder, as an outpatient palliative care doctor, whether it's actually written to say that you have to have a pre-existing relationship with the patient in order to prescribe. And it's talking about the patient-provider relationship itself, and that relationship, even if, 95% of my time is a generic palliative care doctor, you know, I can't take a new patient for the purpose of prescribing. Um, and I've asked for clarification, and I haven't received any, but we'll talk about the implications for how this is carried out. And that actually is a really nice segue to the next part, which is, what does this look like for a patient in reality if they are interested in this? And it's helpful to kind of look around the country. And I'll probably end with this because I see I'm running out of time, um, to see what the different models are. And so in California, some of the people that I've talked with are at the University of California uh, system. And a lot of their hospitals basically have a structured process where, if you are interested, you can go to UC San Diego Health, and they have aid in dying consultants. And they're most often social workers embedded in other practices like oncology or palliative care. And they are the experts at getting all the paperwork completed and making sure all the counseling is done and all the forms are submitted, so that an individual oncologist or primary care doctor who might only be asked to do this once or twice a year doesn't have to like really reinvent the wheel every single time. When I spoke with people in the state of Washington, it didn't seem like there was that much of a robust structure. They described sort of these nonprofit organizations that provide tools, resources that are both patient-facing and provider-facing. This is actually, a group that isn't so dissimilar from the Delaware Quality of Life Coalition. But I talked with a palliative care doctor there, and she said, like, this is what people go to if they're trying to figure out, what hospices can I enroll in if I'm interested in this, or which ones should I avoid, and that sort of thing. New Jersey has taken a different approach. My understanding, and this is anecdotal, is that the vast majority of MAiD prescribing in New Jersey comes from a single person at a single concierge practice that exists almost exclusively for this purpose. Um, and so people have different feelings about the ickiness of this, but basically it's a concierge medicine group. They are fee for service. They don't take insurance. And I think they are the sort of most common source of referral or place of referral for patients who ask their oncologist or ask their primary care doctor about medical aid in dying. I'm not a lawyer. My guess is that this is the type of thing that this language in the law is meant to discourage in Delaware. Um, but I guess there is maybe a little bit of room for interpretation in terms of what's permitted or not. Um, and so, to my knowledge, and I'll just use this, I think, as the transition point. Right now in Delaware, Accent Care Hospice is the only place that I'm aware that is actively offering this to patients that enroll in their hospice services. The last that I've heard from other hospice agencies is that they're not participating. I believe that most of the major healthcare systems are prohibiting this practice from their providers. I have not heard of one that's confirmed that it is allowing their providers to prescribe. Um, I will stop there. I'll let Crystal have a chance to talk through a case, and then hopefully there'll be some time at the end for questions.
Thank you, Dr. Parris. So my name is Crystal. As Dr. Goodall mentioned, I am a social worker and I've worked a couple of different jobs at Accent Care. Um, as of now, we believe we are the only place that is actually participating in MAiD. We started getting training last year. So since Accent Care is, we have sites all over the country in different states, in Oregon, California. So luckily, my colleagues in other states have already taken this on. So it wasn't a really hard process for us to start because we were able to get training from our national team, is what we call them, who have already participated in this. And they were able to get us started and help us. We've also been working closely with Jessica and Pena, who was with the Compassion and Choices organization as well. So to present one of our cases, we have, hold on one second. So far, we have two cases that have been completed from start to finish. We do have one patient that is going through the process right now. He's at the end of it, and he can get his medications any day. That prescription has been place for him. But he hasn't picked them up yet. So whenever he's ready to pick those up, he is able to do so. We have two cases. I'll kind of go over both of them because they're different cases and with different, both patients have different diagnoses, so you can kind of see the difference. Our first patient is a 74-year-old Caucasian male. Was interested in this as last year. He was already on service with us as our patient. He actually signed on with us. He signed on with us in December, so as soon 2025. So as soon as he heard about this, he was interested in participating. His primary hospice diagnosis is prostate cancer. He was starting to have decline, definitely a lot weaker, bed bound, not eating as much, definitely lost a lot of weight. His family was not on board with this process, but he was on board and he wanted to participate. We met with him, me and the assigned RN on the team, met with him several times by himself to make sure, that he wanted to participate. We had tons of goals of care conversations. Um, we have at Accent Care, we have 3 doctors that are participating in the MAiD program. We have some social workers, several nurses that are participating. As Dr. Parris mentioned, this program is voluntary, so it's not something that's mandatory for our staff to participate in. Everyone did receive the trainings, but if you're not comfortable with participating, that's fine. I have been taking the lead in contacting families that are interested and kind of walking everyone through the process. I'm in charge of doing all the paperwork, so I make sure all the paperwork is completed. I make sure I get it back from the doctors, make sure the signatures are there. Um, I actually deliver the prescription once it's ready to the pharmacy that we use, and then the family can pick it up. So it's a whole process that I have down. And then I submit all of the paperwork to the state after the patient has passed away. Um, so we kind of go through it for fine tooth comb. We have it's me, and then we have our executive director, and then our associate executive director. We all kind of take the lead on this project, but I'm like the one that does all the legwork. Um, so as I was talking about our patient, he definitely wanted to participate in this. The nurse and I, like I said, met with the family several times. Um, Once the patient decided to actually take the medication and he went through the whole process, he was found to have capacity. He was able to self ingest the medications, everything. So once we were at that point, um, for accident care, if a family is participating or a patient is participating, staff does not have to be present. If the family does want anyone from our staff to be present, it has to be an RN, and then it has to be a social worker, a chaplain, or a music therapist that's there. Only one of them, but definitely a nurse. In this case, the patient's family did not want any of us present, but did call us after the medication was taken and they felt the patient had passed away. And then me and the RN did go out to pronounce and actually, see the family and check on them. In our first case, the patient who was 74, he took the medication and he passed around an hour and a half later. The family did describe about, the medication being, is thick. You typically mix the powder with 2 to 4 ounces of liquid. It's recommended to use like apple juice or something like that. The patient did say that the medication burned as it was going down. Um, so we had been told before we give the medication, the family should have a non-dairy, non-citric sorbet there, like at the bedside, because that's supposed to help with the burning. We've also been told that using like a little tiny amount of Splenda, if you put that in the powder, that's supposed to also help with the burning. So this patient, he did say that it was burning, but he was able to ingest almost all of the medication. He didn't get to the very bottom of it, just because he fell asleep before he was able to finish it. And this patient, like I said, took an hour and a half before the family said that he had passed. And when we got there to see the family, we were definitely nervous because we didn't know, if the family was going to be upset or how things were going to be because we knew they weren't on board. The patient's sons did fly in to actually be present at the bedside as well. And it was a very like light moment. There was a lot of like laughing and smiling, and the family was happy that they were able to help fulfill his desire and what he wanted at his end of life. And obviously, we were happy that we were able to be a part of that process as well. And I've continued to keep in contact with the family, and everyone's doing really, really well. The patient's wife is still, lives local, and she's fully on board. She's been really great, and she's really been able to accept what he wanted at end of life and come to terms with it. And thankfully, through our bereavement department here at hospice, they've been able to check in on the family regularly as well. Um, our second patient was a 91-year-old Caucasian gentleman. Um, he had his diagnosis was ALS. When he signed on with us, he signed on in um, February 2026, and he literally came on service with us with the goal of taking the MAiD medications. His family was not local. He had private caregivers in the home, was no longer married, and his family, flew in from all over, including London, to be present with him so that he could take the medications. The patient wanted to take the medications before he got to that point where he would not be able to do it himself. So we followed everything, learned from any errors or issues in the first case, and ironed out all the, different nuances. And we were really able to make sure we hit the ground running with this patient to make sure we did it from beginning to end so that this patient could fulfill his end of life goal, and, be able to pass on his own terms. Same thing as we did with the first patient. We made sure we had, several goals of care conversation. Um, Patients did have capacity to make his own decisions. He was able to ingest the medications himself. We had two of our doctors were again involved for assessing capacity and writing the prescription and all of those little details. Um, this patient, all his family was present. He did not want this accent care staff to be present. So I was in close contact with the son via text. Um, and once the patient ingested the medications, he was able to ingest all of it. And he passed after 30 minutes. His son had sent me a text, and it was after hours, after 5. So I contacted our main number so that we could get a nurse out to do the pronouncement. I did not go to the home in this case. But patient's son was extremely happy with how everything went, was really happy that his dad got to fulfill his end of life goal. Family has been super supportive of the patient. I talk to the son pretty regularly still. Um, and they are getting bereavement support. And I really think that um, when so far from what I've seen from these two cases, when the patients are able to, make this decision for themselves, I think sometimes it's helping to make the bereavement piece a little easier um, for the family. So far, is what it seems. Um, but those are our two patients. Um, I know that there's right now, we only know of one pharmacy that is participating in the state of Delaware. We have not tried to find a pharmacy that's closer to, the southern part of Delaware, just because both of our patients, well, actually, our 3 patients, our third one as well, they've all been in Newcastle County. And we've been using Safeway Compounding Pharmacy, who makes the medications for us.